So you do a triamcinolone assisted vitrectomy with or without base shaving. Then a deep, which is a deep, by deep I mean 100%, not 60%, 50%. You keep your diathermy probe to 100% burns you have to give around the incarceration site. Then remove the incarcerated retinal tissue with underlying choroid to the level of bare sclera. Then 1 to 2 rows of prophylactic laser are done around the side. And any bleeding which happens during this procedure can be controlled by additional diathermy or by increasing the infusion pressure. So to understand the concept of chorioretinectomy, I described this first case. He's a 28 years male with a double perforating injury in his right eye. He also had endophthalmitis in this eye. So first procedure was done. We did a lensectomy, and we cleared all this fibrous or the exudative material at the wound site. We repaired the wound. And we did a vitrectomy. We cleared all the hemorrhage, all the exudates. And as the saying goes, in an inflamed eye, we did not touch the retina. We stayed away from the retina. And you can see there's a wound here, the exit wound here in this eye. And we did not do anything to this. And this was 2 months post-operative. There was a thick fibrous growth from the exit wound extending to the fovea. So this is what normally happens in this kind of deep impact trauma. There are these membranes, they grow, and they keep on recurring. You go again, you remove it, and it will again come back. And his patient, after 2 months, his best corrected vision was still counting fingers at 1 meter. And at this stage, we plan to remove this membrane. And this membrane was removed. But because the membrane is coming from below the retina, from the choroid, you can't totally remove it. So now I'm giving 100% diathermy burns around this trauma site, the exit site. And then sparing the larger blood vessels, I'm using cautery to burn out the choroid as much as possible. The choroid and the overlying tissue, and along with the membrane that has formed. So after this is post-operative, 20 days post-operative, the vision was 624 in this eye, and 2 months post-operative, the vision improved to 6/18. You can see small hemorrhages due to the BRVO which had come in this eye, but this is 1 year post-operative. There is no recurrence, and the patient is maintaining a vision of 6/18. So this case I showed to give you an understanding why chorioretinectomy is necessary. And so this is another patient, 21 years male, perforating eye injury with intraocular foreign body. And again, vitrectomy was done. The vitreous hemorrhage was removed. You can see that the hemorrhage, the foreign body was impacted into the retina and injuring the choroid also. So you need not do a chorioretinectomy in all cases, but only in cases in which there is an impaction of the choroid. And then at this side, again you do 100% deep diathermy burns. And after doing this, you plan to do a chorioretinectomy. I'm using cutter in this to remove the excise, the choroid, as well as the other tissues, the overlying. You see, you have to go deep to the bare sclera. You can see that whitish thing now visible. That is the sclera. And there is a small amount of bleeding still there, which you can easily control either by raising the bottle or by diathermy. So once this is done, after this, we remove the intraocular foreign body. Pars plana approach, using the Papay's forceps, and then we suture this wound. And this is post-operative. The patient had a good visual recovery of 6/6 in this eye. This is another case, the 32 years male, injury with a knife. He had a retinal detachment with vitreous hemorrhage and a large area of vitreous incarceration. So again, you can see in the areas in which we have larger areas of vitreous incarceration, we can't go and remove whole of the choroid. So what we generally do is after creating the diathermy, we remove a small strip all along the retinectomy area, so all along the vitreous incarceration, and there is no proliferation seen after that. So here I'm doing a retinectomy, and you see there is a large area of vitreous incarceration along with the retinal incarceration there. After doing a retinectomy, I'll just take the diathermy probe and melt the choroid all around this area. Now this incarceration is free from the surrounding tissue. Now you see with the diathermy probe, I am just creating a 1 millimeter strip all along this area. And after doing this, again the same procedure is followed. You do a fluid gas exchange, you put in oil and close the case. So you need not excise the whole of the choroid here. And this is a post-operative, 2 months post-operative, the best corrected vision was 6/60. 1 year post-op, again you can see an well-attached retina, the silicone oil is removed, and the patient's vision is 6/36. So this is again 2 years, there's no recurrence, there's no growth of any, there's no PVR also. There are some more cases of in which choroidectomy was done. This was a case of iatrogenic perforation during a vitrectomy. I had injured the retina and the choroid. This is a cow horns injury. Again, you can see there's a large patch of vitreous incarceration. This is again a patient of double perforation. And some non-traumatic applications, 36 years female, best corrected vision was 6/36. I think the time is more than not 8 minutes, I think, in this. So this was a case of an angiomatosis, exudative RD and macular edema, and he had undergone multiple sittings of laser and cryo for 2 years. Multiple injections of intravitreal Ozurdex has all been given. This is the pre-operative picture of hers showing a large tumor in the inferior temporal quadrant, and there was a recurrent macular edema which keeps on coming. So we plan to remove the tumor in this case. This was a 25 gauge vitrectomy. We removed the vitreous, and then we removed all the epiretinal membranes which were present. So these membranes, so angiomatosis retina, one characteristic is there's a lot of vitreous cases, and there are many membranes which are overlying the retina, and they are very tough to remove, especially when they are present over the tumor. So the ILM peeling was done to ensure that all these membranes have been removed. And after this, you see still some membranes are left which are being removed. Then these deep diathermy burns were given around the tumor. Actually, initially I had planned only a retinectomy and removal of the tumor in this eye, but the tumor was very adherent to the underlying choroid, so I had to do a chorioretinectomy in this patient. So again, I'm giving 100% deep diathermy burns around this tumor, and then using the cutter, I'm trying to excise the tumor. Now, so infusion pressure is same, 30 millimeters generally I keep, and it's the same. And now you see the tumor was very adherent to the underlying choroid. So there was no other option but to remove the choroid as well. So we plan to do a chorioretinectomy again in this case, and we removed the tumor along with the choroid. In these large choroidal excisions, you have to take care that there should not be an air embolism occurring, which can lead to serious problems like death also. They may be fatal. So you have to take care when you are doing a fluid air exchange. It has to be at a very low pressure, and you have to do a very deep cautery all around the site, and you have to do cauterize the bed also, so that there are no active vessels through which the air can pass through. So after this, again, yes, sir. It can be avoided, but this was an attached retina, so I thought I need not put PFCL and oil in this. Yeah, sure. And this is 6 weeks post-operative. The patient's vision was 6/12, and she had no recurrence after removal of this tumor. So my take-home message is chorioretinectomy is a relatively new procedure. It may prevent exit wound related PVR and fibrous growth over the retina from the wound site, and it may be considered as a prophylactic and a therapeutic option. Thank you.
Thank you, Sangeet, for your excellent presentation. Excellent. Hang on. So basically, the need for a chorioretinectomy is that once the retinal surface is breached up to the choroid by a foreign body or any other or incarceration phenomenon, the possibility of PVR increases exponentially. That arose the need for a procedure like chorioretinectomy, which prevents PVR. Just one last question before I allow you. Sengül Özdek of Turkey, she goes to the extreme of even, suppose there is a exit wound through the center of the macula. She does chorioretinectomy around the, so would you do the same?
So I have also done that, and though I did not show that particular case, the concept is like to prevent at least the surrounding field. Okay, whatever is injured, when the choroid is injured, it means your RPE and the photoreceptors are totally injured at that area. You won't get any vision, whatever you do. So it's better to do a chorioretinectomy and at least prevent the peripheral vision to as much extent as possible.
Audience, any questions?
I have a lot of experience with chorioretinectomy, but what post-operative problem that I face, that is persistent hypotony. Hypotony. Low IOP. So it is better to maintain the IOP with the help of silicone oil only. Silicone oil 5000 centistrokes, that will be helpful.
I think if it depends like whether your retina is attached or not. I won't
Yes.
put a silicone oil just to prevent hypotony in a primary procedure. If there is a chronic hypotony, I may think of putting a silicone oil as a secondary procedure, but not as a primary procedure.
Okay.
Yeah. If your retina is attached. If it is not attached, then definitely.
So thank you so much, Sangeet.